Good evening, everyone. We welcome you all to OrthoTV and Rheumat TV RheumaDigi Conclave. This is the era of novel DMARD Iguratimod. So, to introduce today's speaker, I hand over to our moderator, Dr. Salim Patel.
Yeah, thanks a lot, Dr. Neeraj. Very good evening to all our delegates. Today on this RheumaDigi conclave here in association with Rheumat TV and OrthoTV, I would like to introduce our speaker for the day. It's none other than respected Dr. Padmanabha Shenoy. Uh, Sir is a medical director and a consultant rheumatologist at the Center for Arthritis and Rheumatism Excellence, that is CARES at Cochin. He's been the ex-head of the Department of Rheumatology at the Amrita Institute of Medical Sciences in Cochin, honorary treasurer of the IRA since 2019 onwards, has been the EC member of the IRA in 2015 to 17 and 17 to 2019. He's been the organizing secretary for the IRACON 2016, the treasurer of the IRA Kerala chapter. Sir was an instrumental in starting the first DNB rheumatology in Kerala. He, sir, has been a recipient of multiple academic awards and has multiple publications in various reputed journals to his name. So today's topic for sir is the era of novel DMARDs, that is Iguratimod. I now would hand over the session to Shenoy sir to take over the proceedings. Over to you, sir.
At the outset, good evening, everyone. At the outset, let me thank Zydus for organizing this meeting and Dr. Salim and Neeraj for kind words. So next 20-25 minutes, we will speak about what is the efficacy and safety of Iguratimod in rheumatoid arthritis. As all of us know, Iguratimod is available in the Indian market for last 6 months or so. So what is rheumatoid arthritis? This is a very old picture. Rheumatoid arthritis always used to be a chronic destructive arthritis. There are two pillars. One is chronic, second is destructive. Chronic means it is more than 3 to 4 months. Destructive means there is destruction of joints and erosions. But this funda has changed over the last 15 to 20 years. If you see a rheumatoid arthritis like this, it indicates that you have failed in managing this disease, which can be very easily controlled in today's world. So this upper chart, as you can see here, on the y-axis is disease activity and x-axis is time. So what happens normally is in rheumatoid arthritis, the disease activity increases, but there is fluctuation. There's going on fluctuation. This is natural history. If you treat them early, what happens? The patient becomes normal and there is no damage and patient lead a almost normal life. If you catch them late, after 3 or 4 years, what happens is they develop certain amount of damage. So even if you treat early, there is no damage, patient has a totally normal life. If you treat them late, although they improve, there is certain amount of damage which results in some functional deficit. So what are the advantages of early treatment? One is prevention of damage. Second is better long-term outcome. And third, maybe there's a cure, meaning you can withdraw all the drugs. Studies have shown that if in the first 6 months you treat a patient with rheumatoid arthritis, there's a 50% chance of drug-free remission. So when you see an early arthritis, what are the real challenges? The problem is 35% of them will have a normal ESR and CRP, 50% of them will have negative rheumatoid factor and CCP, and 75% will have normal radiology. So what I'm trying to tell you is this early rheumatoid arthritis is a real challenge because diagnosing rheumatoid arthritis currently is extremely important. Why? Because if you underdiagnose rheumatoid arthritis, the patient will develop damage, and if you overdiagnose it will lead on to false labeling and toxicity of drugs. And the major challenge is to diagnose the patients with early rheumatoid arthritis who will have going to progress and develop damage. So, and once you identify that, and how can you identify? Most of the time, the diagnosis is clinical. And it requires considerable clinical skill and close observation. So once you diagnose rheumatoid arthritis, these are the classical drugs which have been used. One is hydroxychloroquine. Hydroxychloroquine is one of the molecules 200 to 400 milligram per day. It's one of the molecules which is most commonly used, least toxic, and least effective in the management of rheumatoid arthritis. It is safest, but the effects are also quite low. And you can see the lag period means it starts acting around 3 to 6 months. Why this is important? I have seen people changing DMRD at every visit, monthly basis. To start on chloroquine, next month sulfasalazine, third month methotrexate, like that. And then how chloroquine, the advantage is a very safe molecule, does not have any nephrotoxicity or renal toxicity. But the issue is there is a retinal toxicity. What is the percentage? Very, very low, less than 1% after around 1% after 5 years. Year after year, recommendations have come to reduce the monitoring, and now people are saying that first 5 years there is no indication to monitor unless there is a high risk factor, and after 5 years you can start monitoring yearly. So hydroxychloroquine is a very, very safe molecule. And second problem, especially in Indians, is there's a tanning which happens. And third thing is GI toxicity. So it's a very safe drug, but not very, very effective. Sulfasalazine. Sulfasalazine is again another very commonly used drug, but you have to use quite stiff dose, 2 to 3 grams per day. The problem with sulfasalazine is if you have seen a hypersensitivity or DRUS syndrome or significant Stevens-Johnson's, you will always warn a patient, tell that if you have a hypersensitivity, stop it. Somehow it can rarely cause myelosuppression, and another common side effect is oligospermia, especially in males. But it's always reversible. But with sulfasalazine, most important thing is hypersensitivity. Methotrexate, the anchor DMARD, always you have to use quite stiff doses, 20 to 25 milligram per week. People say, how can you use 25 milligram? It has side effects. Yes, it has some minor side effects, but you have to always be used with caution because it's a very cheap drug, and it can control the disease in 30 to 40% of the patients if used very carefully. The problem is with methotrexate is you have to monitor it. Why? Because one, it can cause hepatic fibrosis and cirrhosis, which is irreversible. Also, it can cause bone marrow suppression, which is irreversible. We keep seeing patients, somebody has started methotrexate without counseling the patient properly, and after 2 years or 3 years, patient come back with frank cirrhosis or severe bone marrow suppression. So you have to be very careful when you give methotrexate. Although very effective, it is always a double-edged sword if not used carefully. Leflunomide is another drug which has been used 10 to 20 milligram per day, and it has also toxicity profile similar to methotrexate. And but the cost of leflunomide is at least 10 times that of methotrexate. So these are the anchor DMARDs. These are the DMARDs which have been used. I am not going to biologicals because I will stick to oral molecules today or conventional synthetic DMARDs. To this arena, now we have Iguratimod. So how you use these drugs, basically most of the time it's a combination of disease modifying anti-rheumatoids which are being used, and they are effective in 50 to 60% of patients in reaching remission. So what is Iguratimod? Iguratimod is a newer molecule. It has been there in Japan for a long time. Basically, it inhibits macrophage inhibition factor. Also, it inhibits interleukin 17 and TNF alpha downstream. So, and it inhibits NF kappa B also. So this is, NF kappa B inhibition is the major pathway where it acts. And NF kappa B is one of the transcription factors for the molecule TNF, which is a very key cytokine in the rheumatoid arthritis. So I will just show you some trials. Most of the trials are from Japan. So this is one of the studies which has published in 2007, where they compared the sulfasalazine versus Iguratimod versus placebo. They had 3 arms. To rheumatoid arthritis patients, the 1/3 of them were given Iguratimod, other half were given placebo, and other were given sulfasalazine. So there were 3 arms. And as you can see here, most of them had quite active disease. And if you look at the ACR20 response, what is ACR20 response? 20% reduction in tender joint count, swollen joint count, and inflammatory markers. As you can see here, Iguratimod achieved a 53% ACR20 response, and it was much superior to placebo. While Iguratimod was compared with sulfasalazine, as you can see here, there was no difference. So around 60% of them had ACR20 response. What does this say? It goes on to say that, as you can see here, Iguratimod is as effective and is almost comparable to sulfasalazine. You can very clearly see here. So it is effective. And how much effective? Like sulfasalazine. But always you should remember the dose of sulfasalazine used here is 2 grams, while recommended dose is 3 grams, and they have used the higher doses of Iguratimod. So this is another study which was again published from Japan in 2013. What did they do? Those patients who did not respond to methotrexate, they randomized to 2 arms. Half of them were given Iguratimod plus methotrexate, and half of them were given placebo plus methotrexate. So basically, one group was continued with methotrexate, while in the other arm they added methotrexate, Iguratimod. And the most important thing is methotrexate was used in much lower doses. Why they were lower doses? Because in Japanese people are with a smaller stature, so they don't tolerate methotrexate more than 10 milligram. Methotrexate usually allowed doses more less than 10 milligrams. So mean dose of methotrexate used here is 8 milligram per week. And so you can see here, despite so 164 patients were given Iguratimod plus methotrexate, and 88 were given placebo. As you can see the results here, Iguratimod plus methotrexate achieved a ACR 20 response of around 70%, while methotrexate alone achieved a response of 40%. So definitely, combination of Iguratimod and methotrexate was superior to methotrexate alone. And you can see here, this is shows the baseline, and this dark one shows the 24-week results. As you can see here, the patients with high disease activity remarkably decreased from 40% to 5%. And around 25 to 30% of the patients achieved remission with Iguratimod plus methotrexate. And as you can see here, all the bars, this remission is higher here with Iguratimod plus methotrexate. With methotrexate alone, only 5% achieved remission, while Iguratimod plus methotrexate around 30% achieved remission. So methotrexate with Iguratimod was much superior. And if you look at the adverse events, as you can see here, AST, ALT were increased. That was around 10% of the patient had liver function derangements. Then what did they do? Then in open label, for example, after week 24, I told you till week 24, half of them got placebo, and after 28 weeks, the placebo patients were again treated with Iguratimod as an open label study. And as you can see here, those patients with placebo arm, when Iguratimod was added, they also had a very good response. And in long term, around 48 weeks, 72% of the patients had, 52 weeks, 72% of the patients had ACR2 response, ACR 20 response, which is pretty good, and ACR 50 response of 50%, and ACR 70 response of around 25%. So what it goes on to say is that in long term, around 1 year, if you give Iguratimod plus methotrexate, around 50 to 70% of the patients have reasonably good response. But AST-ALT elevation, again, as you can see here, LFT derangement was around 15 to 20%. And also there were gastrointestinal disorders like diarrhea and stomatitis in around 15 to 20% of the patients. So there are some adverse events, but they are not major. So what you should again here notice, usually in the previous study, as I had told you, the LFT derangement happens in around 5 to 10%. So when you compare methotrexate with Iguratimod, the derangement happens in double number of patients. So this was another study which was published again in 2009, where they have taken patients with rheumatoid arthritis and randomized to 3 groups. One group was given methotrexate, second group was given Iguratimod lower dose initially, then higher dose, and third group was given 50 milligram for 24 weeks. And each arm they had around 160 patients. As you can see from here, Iguratimod, the results of ACR 20, 50, and 70 were all comparable between methotrexate group and Iguratimod group. In the initial slides, I told you that Iguratimod is almost as effective as sulfasalazine, and this study showed at 24 weeks, Iguratimod groups are as effective as methotrexate also. And methotrexate plus Iguratimod combination is better than methotrexate alone. So, and this is a real world data again from Japan, 177 patients. Some of them were given Iguratimod plus methotrexate, and some of them were given without methotrexate. And you can see here, once you give Iguratimod with methotrexate, the response is much better. You can see here, this is delta dash. Delta dash means how much disease activity score has come down. So if you give Iguratimod plus methotrexate, it is much better than giving methotrexate alone or Iguratimod alone. So, and multivariate analysis very clearly demonstrated that whenever you give Iguratimod with methotrexate, is more effective, and also it is more effective in male patients and also in elderly. What are the adverse drug reactions? So the three key things is Iguratimod is as effective as sulfasalazine, as effective as methotrexate, and when you compare Iguratimod plus methotrexate, the efficacy goes up. And always it's better to give in a combination, but the problem is LFT derangement happens in 15 to 20% of the patients once you combine methotrexate with Iguratimod. What are the drug reactions? One is most common is, as I told you, liver function derangements. Some of them have severe abdominal discomfort and GI symptoms, and anemia is another symptom. So usually incidence of all these adverse events peaks around 4th week, and it reduces over time. And whichever GI, LFT, renal changes are more frequent during the initial stages. So this is from the large cohort of patients where you can see that hepatic function abnormality is 7 to 8% of the patients develop per year. Other one is stomatitis, and as I told you, LFT. These are the upper abdominal pain, nausea. All that happens in 2 to 3% of the patients. So most common thing if you look at is one is LFT derangement, second is abdominal discomfort, and GI discomfort. And usually all the side effects happen during the first 1 month. And never give it in pregnancy, never give it in hepatic dysfunction, severe LFT derangement, never give it to patients who are having peptic ulcerative disease because it can cause GI bleed. And also we have to be cautious in patients who are having renal and hepatic derangement and low weight patients. So then we analyzed our data, which was because this is available for almost 1 year now. So we have around 180 patients for in the initial 5 months of this year, from December 2019, when it was available, to May 2020. As you can see here, we have treated 184 patients who had a mean age of 54 years and a disease duration of 8 years, and most of them were seropositive, and they had a mean disease activity of 3.9, which is a mild to moderate disease activity at the time of inclusion. And as you can see here, they had disease 3.9 is not a very high disease activity, but as you can see here, they were on stiff dose of methotrexate sulfasalazine. 75% of them were on methotrexate, 63% were already on sulfasalazine, and leflunomide they were 50%, and some of them were on 76% of them were on steroids, and 60% had experienced biologics. That indicating that we have given Iguratimod to patients who have failed on combination DMARDs or biologics. So what are the results? If you look at the EULAR response, you can see here the good response was there in 32%. EULAR good response means their disease activity score is almost as good as remission or very good control. Moderate response is also quite good. So 50% of the patients responded. Another 50% did not respond. But as you remember, 50% response appears very, you may think that only half of them responded, but this was tried for patient groups which they have failed on combo DMARDs, and some of them have failed on, significant number have failed on biologics also. And 86 of the patients we could exclude because during that December, March, April time, a lot of patients could not follow up because they couldn't physically, we couldn't measure their temperature count and Solon gene count because of the pandemic. And you can see here, over time, the DAS28 decreased from 3.8 to 3.1. So it is a quite good decrease. And 7 of them had LFT derangements, 3 of them had anemia, and 1 patient had gastric disorder. So it's pretty safe, not very bad. So what are the take-home message? First and foremost take-home message is Iguratimod has a moderate efficacy as DMARD. I won't say it's a wonder drug, but it is works. Sorry, excuse me. And it's relatively safe. Side effects are not that very threatening side effects. But the problem is there are lack of well-controlled clinical trials. And we need data on inhibition of structural progression. Rheumatoid arthritis drug is called disease modifying because we need data on inhibition of structural progression. Once it prevents erosions, once it prevents joint space narrowing, then only you can call it as a disease modifying anti-rheumatoid. We don't have such a data in Iguratimod. Maybe people like Zydus should come up with this study, innovative studies, and conduct Indian trials with these molecules so that in Indian population we will have a better data. Thank you for patient listening. This is my where I work. I work in Cochin. This is my team. Thank you for patient listening.
Thank you, sir. Thank you. An excellent presentation, very crisp and to the point. So we have a few questions regarding the molecule. So as you said, sir, the first question which has come up is, as an add-on therapy to methotrexate, when would you like to introduce Iguratimod? Maybe after 2 months, 3 months of the initial DMARD therapy, or when, sir?
Once you start on methotrexate, usually the patient respond, as I told you, there's a lag period of 3 to 4 months. If somebody does not respond in 3 to 4 months, then maybe that is the time you should introduce Iguratimod.
Right. So at least 3 to 4 months with the initial.
Yeah, therapy. minimum. Yeah.
Right. So, sir, if like suppose if a patient is on 2 drugs like methotrexate or hydroxychloroquine or sulfasalazine, for instance. So then when we add on Iguratimod, do we need to stop any one of these?
You can stop sulfasalazine and add on Iguratimod. That will be the best strategy.
That will be the best.
Yeah, because combination of methotrexate and Iguratimod works best.
Right, sir. Right. Great. Sir. So another question is about monotherapy of Iguratimod. Can we start it as a monotherapy?
We can give it to patients who are intolerant to methotrexate or intolerant to sulfasalazine, but usually the combination therapy works better. But definitely, yes, if somebody is intolerant to methotrexate or if there's some other contraindication to methotrexate, definitely you can give a monotherapy. But the problem is there is not much. Always it is the results are better when you combine with methotrexate.
With methotrexate. Right, sir. Right. Another question also, this is from the orthopedic point of view. A lot of ankylosing spondylitis patients we see, and even rheumatologists are also seeing a good number of angspon patients. So what is your position of treating with Iguratimod in such cases?
There is some early data that Iguratimod may work, but there is not conclusive. There is no the problem with Iguratimod is there is no data on structural progression, whether it can inhibit syndesmophytes, whether it can inhibit decreased number of erosion. We don't know that because some people say that Iguratimod is just an NSAID. But we see response. People improve with Iguratimod, but we need better trials and studies.
Right, sir. Right. As you rightly said, sir, about the Indian trials. I mean, those are the ones where this molecule is really struggling. But we saw your data, sir. It was an excellent data from the case where we've seen good results with Iguratimod. Right, sir. And so coming to one more question regarding, again, from the orthopedic point of view, when we take up patients for joint replacements, rheumatoid patients, there is a saying that we should stop the DMARDs before the surgery. So any particular one, if so, yes, then which drug should we stop, sir?
See, there is no see, if somebody is going for joint replacement or joint surgery, we just say most of the time steroids. It's better that somebody is off steroids or is on a minimum dose of steroids.
Right.
And second dangerous drug, what I have seen, usually there is no recommendation to stop most of the drugs except biologics. If somebody is on biologics, it's better to be like you give a gap based on their half-life. For example, ectinacet you delay it by 1 month, infliximab for 2 months or 3 months, adalimumab for 3 months again. So something similar. But what I've seen in experience is steroids better to avoid because it delays wound healing, increases infection to a great extent. If somebody has given an intraarticular injection, never operate on that knee for next 6 months because chance of infection greatly goes up. And third drug what I have seen is leflunomide, especially in hand and foot surgeries, where you have a lot of soft tissue manipulation. Leflunomide decreases the wound healing. And methotrexate is absolutely safe. Chloroquine is absolutely safe. Sulfasalazine is okay.
Right. So we need not discontinue them, sir, when suppose you are taking up a patient for surgery.
Yes, steroids. You have to better to plan the surgery when the patient is off steroids.
Right. But DMARDs we can continue.
You can continue because otherwise what happens is previously people used to continue for 1.5 months. The problem is the disease will flare up. You may have cured one knee, but other ankles and hips and other knee will be, the patient will ultimately curse you if you stop the DMARDs and the patient flares up. So the entire purpose is lost.
Absolutely, absolutely. Yeah, Dr. Neeraj, you can ask a few questions. Yeah.
Thank you, sir. So before this, few years back, I used to get almost one new rheumatoid patient every day. And now because one patient I treated and he was one of the leaders of the group. But nowadays I don't get so many. So my experience is very limited with these newer drugs. So I am treating I'll just give you 1 or 2 case scenarios. I am treating the patient with say hydroxychloroquine, salazopyrene and methotrexate 15 milligram. And in spite of that, patient is getting exacerbations. So how does now, what dose adjustment should I do and introduce Zyramod? That is what I wanted to ask.
You can stop sulfasalazine and substitute with Iguratimod. That's one way of looking at it. Or if somebody has bad prognostic factors like CCP is very high, ESR is very high, CRP is high, temperature is his disease activity score is high. Another option is going for biologicals and targeted synthetic DMARDs. So where we can place Iguratimod is once somebody fails on methotrexate chloroquine combination, you can add on as Iguratimod. For a brief period of time, the patient is not affording a biological. That is the place you can.
Okay. Can we substitute methotrexate altogether? A patient is not tolerating, having a lot of vomiting.
Yes, definitely you can substitute, but efficacy comes down.
Okay. So means the combination of hydroxychloroquine, salazopyrene and Zyramod is not as good as with methotrexate.
We don't have data. That's what I can say. Methotrexate, okay. Usually Iguratimod works best with methotrexate. Okay. We don't have a data of combination of sulfasalazine and Iguratimod. Maybe it will work, but we need data.
What about the maximum dose which we can give of everything together?
50 milligrams of Iguratimod, methotrexate 50 to 20 milligrams, 20 milligrams of methotrexate, and chloroquine around 200 to 400 milligrams, depending on it.
So 50 milligram is the maximum we can reach with this. We should not go higher than that.
No.
And is there a way that we need to stop it? So should we bring it back to 25 and then stop it, or how do we go about it?
If we stop it only in two conditions. Once the patient is in remission, definitely we can taper and stop 25 milligrams. Then after a couple of months, you can stop. If somebody has a side effect, definitely you have to abruptly stop.
So what is the main side effect that we should watch out for?
Liver function, the LFT derangements. That's right.
Okay.
Yeah, and the GA disturbance sometimes, and anemia rare.
Yeah,
Okay.
and
So,
yeah, Neeraj,
yes, Salim, go ahead. Yeah, I'm finished with my questions.
Right. So one last question, which most of the audience would like to know: how long can we continue Iguratimod in a safe mode?
See, Iguratimod, we don't know. That's what I'm telling to you. All our experience are limited. We have patients for more 1 year, 6 months. Patients are doing relatively well, but whether the structural progression is inhibited, we don't know. So we need more data on that. We need serial X-rays to see whether the erosions are progressing, how the patients are behaving long term. Side effects doesn't appear to be a huge concern as far as Iguratimod is concerned. There is no renal toxicity till now. As more data comes in, definitely we will keep you posted.
Right.
Okay.
Excellent, sir. Excellent. Yeah, Neeraj, any other questions from
No,
you?
that's all from my side.
Right, sir. So, sir, we thank you for your time and
Thank
for this participation on this excellent event on a Saturday night. Thank you, sir, for all the beautiful things you have spoken about the molecule. And we wish you a very happy weekend, and also be safe. And to all our viewers, to be safe and be well protected. Thank you, sir.
Be safe.
Bye-bye.
Thank you. Thank
Thank
you.
you,
Good
sir.
night.
Bye, sir.
Bye-bye.
Thank you.
Good night. Bye-bye.